Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. Right, so today we're going to talk about dysphagia. I know we had a lecture about dysphagia for the NACOSKI, but this is going to be very exclusively for the MCQ one. All right, so dysphagia, today we are going to learn about the pattern recognition from the history. Like, what are the things that are essential to know from the history? So usually if you get a scenario, obviously they will provide you with a few information and the scenario. So based on those points or clues that you read the scenario, and based on that you find, and then you can tell, oh, this could be this part, or this could be this kind of dysphagia. Okay, so the pattern recognition of dysphagia from the history. What are those patterns? I will mention every single one of them. Another thing which is very, very important when it comes to dysphagia is it solid or it is solid and liquid? Like if your patient has dysphagia, is it only because when he eats something really hard and solid, or it is happening regardless of the consistency of the food? Regardless of what kind of food he is drinking or eating, the patient feels that dysphagia or has that dysphagia. Very important. So it means you cannot miss it. You have to know it. If you don't know it, it's going to be very hard to distinguish that which kind of dysphagia I'm dealing with. So oropharyngeal clues and aspiration risk. So usually we have aspiration as a most common complication or the dangerous complication of oropharyngeal dysphagia, not esophageal dysphagia. The key diagnosis, is it carcinoma that I'm dealing with? The patient has dysphagia because of the carcinoma, or this is because of the peptic stricture, or this is because of the achalasia, or this is because of diffuse esophageal spasm, or maybe this dysphagia is because of the scleroderma or zinca diverticulum. So we're going to cover every single one of them. Okay. If it is carcinoma, how the patient is going to present. If it is peptic stricture, what is going to be the difference between carcinoma and peptic stricture? But what if the patient has achalasia? Then it comes the typical type of the food, solid and liquid at the same time. And what if the patient has for both of them, but the patient has diffuse esophageal spasm, scleroderma, and zinca diverticulum? We're going to cover every single one of them. So before we cover them one by one, so there is something that we have to know before going deep into those types. So what is dysphagia? Dysphagia is difficulty swallowing. Then we have another term which is called odenophagia. It means the patient has not difficulty swallowing, the patient has painful swallowing. When he swallows, it is very painful. Always separate the true dysphagia from the globus or sore throat, because it can happen to someone who has sore throat as well. So we need to be able to distinguish that is it a global, or it is esophageal, or just a sore throat that is temporary. First example, step. Decide whether the problem is in oropharyngeal or esophageal. This immediately narrows the differential and guides the testing. So if you know it is oropharyngeal or dysphageal, esophageal, it can help you to come up with a shorter list of conditions. And I will tell you how. Then decide whether the esophageal dysphagia is mechanical or mortality related. So let's get to this point. So the patient comes and tell you that I have problem with swallowing. So for me, first I have to know whether the patient has problem swallowing. Is it sticking? The patient cannot move it down, or the patient has pain while swallowing. Now, when that's out of the way, now I'm focusing on whether the patient has this with initiating the swallowing function, or the patient can initiate but cannot push it downward. If the patient has problem with initiating or starting the swallowing function, it is more likely to be neurological, muscular, and the risk of aspiration is high. So if they want to test you on oropharyngeal difficulty or oropharyngeal dysphagia, which the patient cannot, you put the food in the patient's mouth, the patient cannot initiate the swallowing function. He cannot start to push it. So if the patient cannot start it, it means the nervous system is involved, whether the patient has a stroke, whether the patient has neuromuscular dysfunction, or the patient has Parkinsonism, which again, it's going to come back to the neurodegenerative or neuromuscular issue. Now, on the right side, esophageal dysphagia is the patient can start swallowing. He swallows the food, but cannot push it downward. Like along the way, it gets stuck. So if you can start the swallowing, but the esophageal cannot push it down, it means there is a problem with the peristaltic movement. It means I can take it down to the esophagus pipe, but the pipe has to have those peristaltic movement to push it downward and put it in the stomach. So now, if there is a peristaltic or the motility disorder, it could be mechanical and it could be motility related condition. Use solid versus liquid pattern. So in this case, we only have solid, which eventually lead to the liquid form too, or we have solid and liquid at the same time. Now, if the patient has mechanical or motility issue, mechanical is like obstruction, like having a cancer. There's an obstruction. You have a cancer in the esophagus that physically blocks the food from going downward, right? That's mechanical. Or there is a ring. There's a ring like this that closes the esophagus and doesn't allow the food to go down. Or there's a stricture, same thing. Or there is a motility issue. Now for this, we have to differentiate. So this pattern recognition is a favorite MCQ1 shortcut. So it means these are the most commonly tested part of the dysphagia in the licensing exam. So oropharyngeal dysphagia, as I mentioned before, it is the patient has problem with initiating, with starting swallowing. You put the food in the patient mouth and it stays there. The patient cannot move it downward. Okay. So if the patient has difficulty starting to swallow, what happens? Choking, coughing, wet voice, nasal regurgitation. So if you have any of them in the scenario, think about oropharyngeal dysphagia. Usually, the patient will have a stroke, Parkinsonism, or bulbar disease, myasthenia gravis, or diverticulum, zinker diverticulum. The major danger is aspiration, crude, difficulty initiating swallow, plus proximal muscle problem. Esophageal dysphagia, swallow starts normally. It means you can start the swallow, but then the food seems to get stuck. There is no peristaltic movement to push it forward. Or there is peristaltic movement, but there is a blockage, an obstruction, localized to the chest or lower throat. Next, decide mechanical obstruction or motility. If it is mechanical, look for it. Is it a cancer? Is it a structure? Is it a ring? What is blocking it? If it is motility, find the type and treat it. Classic questions, solid only, which is usually, if it is solid, then we think about, is it progressive or it is intermittent? Is it progressive or it is occasionally? The patient, let's say, have problem with eating solid food occasionally. Sometimes he is okay, sometimes he's not okay. Or he is progressively getting worse and worse and worse. If it is progressively, think about two things. Either it is stricture or it is the cancer. If it is intermittent, Or if it is occasionally, the patient says, when I eat the solid food, for example, bread, meat, this and that, sometimes it's okay, but sometimes it's not okay. It hurts or it is getting stuck. So in that case, it is the ring or the web. So classic question, solid only or both solid and liquid, intermittent or progressive? So these are the questions. If you don't have it, you have to find the answer. If you don't have the answer, you cannot find a type. So you need to have these answer. Is it solid? Is it solid or liquid? Is it intermittent? Is it progressive? If you know them, then it is easy to pinpoint the actual condition. Now the clue, food stick after swallowing begins esophageal problem. Aspiration pneumonia secondary to oropharyngeal dysphagia is one of the commonly tested topic in MCCQ1 that they love to ask you that what is the dangerous or the most common complication of oropharyngeal dysphagia, and that is the aspiration pneumonia. And I believe you guys have this in your note. All right, so mechanical obstruction versus motility disorder. For mechanical obstruction, if there is a blockage, if there is an obstruction, right? Usually, if this is a mechanical, there is a solid food dysphagia. It means the patient have no problem with liquid. He drinks fine, but when he eats solid food like bread, rice, especially meat, it gets stuck. And if it is the case, then the next question should be, I know it is solid. Is it progressive or it is intermittent? If it is progressive pattern, it is cancer or peptic stricture. Now, based on the condition of cancer, if the age is more than 50, look at this, age is more than 50, the patient has weight loss and it is progressive, it is cancer until proven otherwise. So if these are not the condition, then it is peptic stricture. Now, if the patient has intermittent solid only pattern, it suggests that the patient has either ring or web. Now, key causes could be for the mechanical cancer, peptic, or the ring. Three things. So if the patient has problem with only solid food, think about three things. It's either cancer or peptic stricture, or the patient has ring or web. Now, if my patient has constitutional sign and symptom, night sweat, weight loss, over 50, lumps and bumps, bleeding, it is cancer. If my patient has long history of reflux disease, it is most likely to be peptic stricture. These two are progressive solid food dysphagia. Now, solid intermittent dysphagia. For this one, the patient has solid food dysphagia, but intermittently, occasionally, not always. Okay, done. Moving to motility disorder. For the motility disorder, I made a mnemonic to make it very easy, SAT. Just remember this mnemonic, SAT. S stands for scleroderma. Motility disorder that causes dysphagia is SAT. Scleroderma. A, achalasia. D, diffuse esophageal spasm or diabetic dysmotility. What causes the dysmotility or motility disorder dysphagia? SAT. S stands for scleroderma. A stands for achalasia. D stands for diffuse esophageal spasm or diabetic dysmotility. The golden standard for physiological test is esophageal manometry. Okay? So for any motility, manometry. Now for mechanical obstruction, let's say if there is a typical case, how should I know that this is a cancer? This is a cancer. So we know that for mechanical, for the cancer, usually it is progressive. The patient will be older age, more than 50. Dysphagia with the solid food will be there. And the symptoms worsen within weeks to months. The red flag, the patient will have weight loss, anemia, a persistent progressive pattern. Think about esophageal cancer or peptic stricture. Now let's say for the cancer, the typical scenario, 68. So it means it is more than 50. With a progressive solid food dysphagia and weight loss. So I have 68, which is more than 50. It is progressive. It is solid food, and the patient has weight loss. It is cancer until proven otherwise. Okay? And now, if it is intermittent, let's say for the intermittent, the patient has intermittent dysphagia, often with a large food bolus such as meat or bread, usually no major weight loss. The patient will not have it. Symptoms comes and goes. Sometimes okay, sometimes it's not okay. And it is usually ring or web. So the typical scenario would be like this. A patient says the stick, we say it kebab, right? So kebab gets stuck occasionally, not always, occasionally, but liquids are fine. It means the patient has ring or webs. If it is lower, ring. If it is above, web. Now let's go check for the motility disorder typical scenario. For motility disorder, we said that we have a mnemonic, which is for four things, but three words, SAD, right? S-A-D. S stands for scleroderma, A stands for achalasia, D stands for diffuse esophageal spasm, and D stands for diabetic dysmotility. So, typical scenario, a patient has slowly worsening dysphagia to both solid and liquid. So if the patient has progressive dysphagia to both solid and liquid, it is achalasia until proven otherwise. Like when we say if the patient has progressive solid food dysphagia, it is cancer until proven otherwise. Here we say if the patient has progressive dysphagia to solid and liquid, is achalasia until proven otherwise. Unless the patient has a typical scenario of scleroderma. For example, if they want to test you on scleroderma, probably I have another slide to explain it in details. It will mention the patient has systemic disease. The patient is taking, for example, a steroid, or they will mention the patient has tight skin. They give you a clue that the patient also has systemic issue. So it is more likely to be a scleroderma. And also there's a fine differential between achalasia and scleroderma, which is about the lower esophageal sphincter, which fails in achalasia, but it is low esophageal sphincter in scleroderma. I will show you the slide. Now, let's say this was progressive, right? If the patient has progressive dysphagia for both solid and liquid, it is achalasia or scleroderma. What if it is intermittent? The patient says, sometimes I drink, I'm fine. I eat the bread, I'm fine. But sometimes when I eat or drink, I have pain. Same thing that we had for the solid only. Now the patient has the same thing, but with both solid and liquid. It could be esophageal, diffuse esophageal spasm. This one, they may give you also a scenario about somebody who, let's say a typical scenario we have here. A patient has episodic. Episodic, it means sometimes he is okay, sometimes he is not okay. It's like an episode. Chest pain and intermittent dysphagia to solid and liquid. Sometimes they mention the patient has chest pain. They're not saying the patient has esophageal pain. They will mention chest pain. And when the patient takes nitrate or calcium channel blocker, the patient gets better. And it will deviate you from the main point, which is the esophagia. You might go to heart disease and pick for example, MI or ischemic heart disease or angina and so on and so forth. Because this is very characteristic, but it has relation to the food as opposed to angina. which that also has relation, but not very specific like this. So this is the picture that this is for esophageal cancer, for peptic structure, for the ring, and for the web. Now, key, I think this is what we covered yesterday. No, I believe it was last Saturday. Yeah, we covered it for the dysphagia when we did this, that what are the questions that we need to ask in the history? Difficulty initiating the swallowing, solid, liquids, or both? Is it intermittent or progressive? Does the patient have regurgitation, voice change, coughing, aspiration, history of heartburn or reflux? Because if the patient has it, it's more likely to be peptic structure, right? Weight loss, changes in habit or eating. If the patient has it, probably it's going to be cancer. Red flags, progressive dysphagia, weight loss older than 50 is red flag for the cancer. Aspiration for oropharyngeal, right? Severe odenophagia, immunocompromised. If the patient has this severe odenophagia, then think about either if the patient is immunocompromised, if the patient is having any sort of chemotherapy or receiving any sort of chemotherapy or immunosuppressant, and the patient has odenophagia. If the patient has odenophagia, think about viral and candidiasis. Viral and candidiasis. The difference is if it is whitish and diffuse, it is candidiasis. If it is ulcerative, it is viral. That's the difference. Because they both can happen in diabetic patient, they both can happen in somebody who is receiving chemo and radiation, they both can happen to somebody who has been receiving immunosuppressant. So both of them are painful. But the difference between the viral esophagitis and candidiasis esophagitis, that candidiasis is diffuse whitish, but viral is ulcerative group of ulcers, not like a diffuse whitish. And both of them are odenophagia. I mean, painful swallowing. Acute complete food obstruction and inability to swallow secretion. Example, progressive solid dysphagia plus weight losses, cancer until proven otherwise. We did mention this. This is very important slide, very important slide. This is how you differentiate the major esophageal motor disease, like achalasia, scleroderma, and diffuse spasm. So for both of these two, progressive, solid and liquid dysphagia. For these two, achalasia and scleroderma. For both of them are progressive, solid, and liquid. For this one, it is intermittent, solid, and liquid. It means sometimes okay, sometimes not okay. So now let's go one by one. So the pattern for the achalasia is solid plus liquid regurgitation, and it's progressive. Scleroderma, reflux plus dysphagia, lower esophageal sphincter tone. For diffuse spasm, it is intermittent dysphagia plus chest pain. The key mechanism fail, lower esophageal sphincter relaxation. So please remember this. They might ask you this in the exam. So it is failed, lower esophageal sphincter relaxation, but in scleroderma, they may mention low esophageal sphincter tone. Okay? But this one is weak, non-peristaltic, high pressure contraction. Classic clue. This will, I will show you the picture for this one. For achalasia, it's a bird's beak. Appearance or characteristic radiographic finding. Bird beak, like this. Look at this. It looks like a bird, right? This is the bird beak. We call it in our language, منقار یا نول kabutar. So it is called bird beak. Sometimes they give you a scenario about someone who has difficulty with swallowing food, regardless of the consistency of food, liquid and solid. and this is the X-ray. So when you see the bird peak, you can tell it is achalasia. Okay. Now for this one, usually they give you a scenario about the connective tissue disease and the patient will have severe reflux disease. For this one, diffuse spasm, the X-ray will have corkscrew esophagus. This is the corkscrew spasm. Do you guys see my cursor? Yeah, like this.
Yeah.
This is called corkscrew. And for all of them, since it is a motor disorder, it is monometry for all of them. So the core treatment is pneumatic dilation, POEM, or botulinum toxin. For scleroderma is aggressive GERD therapy like PPI and surgery. For spasm, nitrates and calcium channel blocker. Okay. And this is the X-ray, which we did talk about it. This is diffuse esophageal spasm, and this is achalasia. Now, let's say how the scenario will appear so that you can tell which one is which. Let's say for achalasia. For achalasia, a 32-year-old patient has gradual worsening dysphagia to both solid and liquid. So the patient has gradually, it means it's progressively, right? Liquid and solid regurgitation and digested food and weight loss, barium swallow shows bird peak. That is characteristic of achalasia, and it is both for solid and liquid. So the key differentiate clue, both solid and liquid, progressive course, regurgitation, bird's peak, and best test is monometry. Think achalasia when dysphagia is progressive and involves both solid and liquid. Now, scleroderma, a 48-year-old woman with a systemic sclerosis. See, they gave away a very important information, which is about scleroderma. Someone with a systemic sclerosis will have sclerodermic dysphagia, right? So the patient is have systemic sclerosis, has severe heartburn, which is another clue, and dysphagia. Esophageal monometry shows low esophageal sphincter pressure, which is another key finding, right? With a weak distal peristalsis. So the key differential, non-systemic sclerosis, which is a connective tissue disorder, severe GERD or reflux, low LES tone, weak distal esophageal, and Vestis monometry. Think scleroderma when reflux is prominent and LES is weak. Now for diffuse esophageal spasm. For this one, we have intermittent solid liquid. Okay, a 45-year-old patient has intermittent dysphagia to solid and liquid. So it means sometimes he has, sometimes he doesn't. With an episode of non-cardiac chest pain. He has a chest pain, but it's not related to heart. Non-cardiac chest pain. Barium swallow may shows a corkscrew esophagus. This is corkscrew esophagus. Okay, the key differential, intermittent symptom, chest pain, solid and liquid, corkscrew esophagus, best testis monometry. Think diffuse esophageal spasm when intermittent dysphagia is associated with chest pain. And this is the scleroderma, which we did cover it in the previous lecture. Let's talk about achalasia. Achalasia, if there is one question in dysphagia, it will be about achalasia. So very commonly tested. They love to test achalasia for some reason. Okay. There will be more questions. I'm just saying, if they choose to bring one question, it will be from achalasia. This is how important this topic is. Dysphagia to solid and liquid, regurgitation of retained food, chest discomfort possible, symptoms often gradual and progressive, investigation barium swallow, bird peaks narrowing, endoscopy may show retained food but often normal, monometry. So if they ask you what is the initial test, endoscopy. What is the next step? Always the barium. And what is the definitive test? Monometry. Okay, pathophysiology. This one might be in the exam. To be honest, all these four might be in the exam. If I happen to make a question from the achalasia, I will ask you this question. So what is the which one of the following is correct about the pathophysiology of achalasia? A, degenerative of Auerbach plexus, increased lower esophageal sphincter pressure, incomplete LES relaxation with swallowing, A, peristalsis of the esophageal body. E, all of the above. Okay, please remember this. Management, again, if they ask you what is the first, best, or initial treatment, pneumatic dilation. If they ask you what is the temporary treatment, is botulinum toxin. And then what is the last resort? The last resort could be myotomy. You can do myotomy endoscopy and you can do surgical. Okay, I think I do have this slide for it. Per exam, in an older patient with achalasia-like symptoms and weight loss, always consider pseudoachalasia from malignancy. Best one-line clue, bird beak plus solid and liquid. Now let's talk about this diffuse esophageal spasm and scleroderma. So for this one, intermittent solid and liquid, chest pain, which is non-cardiac, right? Barium shows corkscrew pattern, endoscopy of a normal. Again, if they ask you, that will be the best initial. Treatment reassurance, nitrate and calcium channel blocker, select refractory case, myotomy. That will be the last result. The key, intermittent dysphagia plus non-cardiac intermittent dysphagia to both solid and liquid plus non-cardiogenic cardiac chest pain. Maybe I should put here solid and liquid. Okay, scleroderma. For the scleroderma, distal smooth muscle, please remember this. Sometimes they only mention, they probably only mention one of the clue, and this would be one of those clues. Distal smooth muscle weakness and aperistalsis, low esophageal sphincter pressure, severe reflex. Dysphagia may result from dysmotility, reflex, or stricture. Monometry, treatment, aggressive GERD therapy, which is the PPI, and then if it doesn't help, then anti-reflux surgery. Connective tissue, which we did talk about it, that they may give you a scenario about someone who has systemic sclerosis, that gives it away. Structural causes to recognize fast. Esophageal carcinoma, older, dysphagia to solid, and weight loss. Peptic structure, if the patient has progressive, long-standing GERD, progressive to solid dysphagia, distal smooth narrowing. Distal smooth narrowing, endoscopy, dilation, indefinite, PPI. So this is almost the same thing, but usually it doesn't have all the characteristic finding of the cancer, like elderly, weight loss, lumps and bumps, and this and that. Lower esophageal ring, intermediate solid, only dysphagia, meat, bread, triggers, non-progressive, it is intermittent, and rings, classic. So intermittent solid food, dysphagia. Zinker, this is very interesting. So Zinker is difficulty initiating swallowing. The patient, if they ask you about this, they will definitely mention halitosis. Like that is something really important to have. Why? Because there is a pouch with a remain food. When there is a pouch with a remain food, what does it cause? It causes bad smell. So if the patient has difficulty initiating swallow and the patient has regurgitation and halitosis, it is more likely to be Zinker diverticulum. So halitosis, regurgitation, feeling something stuck in the throat, the patient usually do this. There is something right here, I know it's a food or something stuck here. I swallow, the food goes down. The patient is not losing any weight. It means the food he eats that goes to the stomach, he gets it, he absorbs it, he digests it. But there is still a food or something here that he can feel it. Not only he can feel it, he has regurgitation. And also when he starts swallowing, he has problem with the starting swallow. Why? Because there's a pouch, right? But still he can manage to take it down. But this pouch is always giving him a feeling of something stuck here. And always he does this. There's something stuck here. Like we have chest pain for the heart, they usually do this. This is the same universal sign for a Zenka diverticulum. And this is Zenka diverticulum. This is a pouch, these are the food, and it causes the bad smell. And this is how it looks like in X-ray. Another thing that you guys have to remember if you're doing the MCQ1, they might ask you about the anatomical location of the Zenka diverticulum. Like probably it is below the inferior pharyngeal constrictor and above the cricopharyngeal muscle. So cricopharyngeal muscle, so this is the out pouch, right? The Zenka diverticulum out pouch. And this is the muscle, cricopharyngeal muscle. And this is the inferior pharyngeal constrictor. So below this, above this. And it could be endoscopically and it could be surgically treated. Remember, when it comes to treatment, if you have a typical picture of Zenker diverticulum and the patient, or if it is typical picture and the patient has symptoms, it has to be treated with a surgery, endoscopy or surgical or open surgery, right? But if incidentally you're doing something else and incidentally you're finding the Zenker diverticulum that the patient has no complaint, the patient is asymptomatic, he doesn't even know that he has it. In that case, you don't have to treat it. If it is asymptomatic, no treatment. If it is symptomatic, endoscopy or open surgery. Now, Whipps, rings, infectious esophagitis, Palmer-Vincent syndrome, and eosinophilic esophagitis. For the whips and rings, we did cover it, right? This is not complete. This is complete. For the Palmer-Vincent syndrome, there's a triad. If they want to test you on this one, they will mention someone who has anemia, iron deficiency. Maybe they mention it directly. For example, the patient iron is low. Or they may mention the patient has fatigue, tiredness, fine hair, and the nails are deformed, like a spoon-shaped nail, which is colonacia, right? Spoon-shaped nail. So maybe they mention it directly, like iron deficiency, or maybe they mention it indirectly. So pay attention to the scenario. Let's say there is a woman, 35 years old woman, the patient is fatigued, the patient has fine hair, the patient has deformed nail, which looks like spoon, and the patient has problem with swallowing. And when you check the patient's mouth, the patient has glossitis 2. So all of them is dysphagia, also the colonacia, iron deficiency, and stomatitis. The dysphagia is usually whip. They're all together is a triad for the Palmer-Vincent syndrome. Okay, so anemia, whip, iron deficiency. Anemia, whip, or dysphagia. These are the triad of the Palmer deficiency. So infectious esophagitis. For infectious esophagitis, if they're asking you which one of the following is the most common infectious esophagitis, it is candidiasis. Okay, it is candidiasis. Then it is herpes simplex virus. Then it is cytomegalovirus. So if it is diffuse, again, if it is diffuse, whitish, plaque plus odonophagia, it is candidiasis. If it is ulcerative, punched out ulcer, they are herpes simplex or cytomegalovirus. Eosinophilic, if they want to test you on eosinophilic, usually they give you a scenario of allergy. For example, the patient has asthma, the patient has atopia, the patient has seasonal allergy, the patient has food allergy, and then they will give you dysphagia. So there will be a previous history positive about allergy. Then the patient will have dysphagia. So if you see any history of allergy plus dysphagia, think about eosinophilic dysphagia. And these are the scenario. For example, what kind of scenario we might get for the herpes simplex esophagitis, virus esophagitis? A 34-year-old immunocompromised patient presents with severe odonophagia and retroesternal pain. And endoscopy shows focal esophageal ulcer. See, it shows ulcer, not whitish plaque, without diffuse white plaque. So it is differentiating the candidiasis. It is not candidiasis, so it is ulcerative. If it is odonophagia, it is not white. It is ulcerative. It is herpes simplex or cytomegalovirus. So the treatment will be acyclovir or valsiclovir endoscopy plus biopsy. Think herpes simplex virus when painful swallowing occurs with the ulcerative lesions. Now, candidiasis esophagitis. A 58-year-old man with a diabetes and recent steroid exposure developed painful swallowing. Endoscopy reveals whitish yellow plaque coated and coated esophagus. So the key differential is the risk factor, the same thing that we had it for the herpes simplex, diabetes mellitus, chemotherapy, immunocompromised patient. This is odonophagia, right? It has odonophagia, white plaques on endoscopy, as opposed to viral, which is focal ulceration. Most common infection of esophagitis, more than HIV, herpes simplex. Treatment is nystatin and fluconazole. The candida when odonophagia, think candida when odonophagia is associated with a white plaque. Now for eosinophilic esophagitis. Eosinophilic esophagitis, usually the patient has history of what? Allergy. So a 25-year-old man with asthma, see, and eczema has recurrent food bolus impaction and dysphagia. Endoscopy suggests ring and biopsy confirms eosinophilic infiltration. So maybe they will ask you what is the confirmatory test or investigation for esophagitis. Remember, endoscopy, biopsy. Okay. The key differential, usually young patient, usually male, but atopic, right? Food impaction and dysphagia. Endoscopy shows ring. Dysphagia diagnosis usually biopsy. Treatments, elimination of diet. This is the first best treatment. If they ask you what is the best initial treatment of eosinophilic esophagitis, always go after diet. Don't start the treatment. The first best treatment is non-pharmacological treatment. We go after the diet or the food that causes this allergy or esophagitis, this inflammation. So once we eliminated all those diets that they triggered the esophagitis, then the patient is still not improving, I will decide to go ahead and do the steroid. Obviously the swallowing one, right? Plus swallow the steroid, fluticasone. Think about esophagitis, eosinophilic esophagitis when dysphagia occurs with atopia and food impaction. Now, Palmer-Vincent syndrome. We said the patient will have dysphagia, iron deficiency, right? So 43-year-old woman with a fatigue. See, fatigue is sign of iron deficiency, but still it gives it away here. Iron deficiency anemia, reports progressive dysphagia, endoscopy identify upper esophageal web. So iron deficiency dysphagia is Palmer-Vincent syndrome. Key differential clues, classic triaditis, iron deficiency anemia, dysphagia, plus esophageal web. So dysphagia is secondary to the esophageal web. Usually upper esophagus, consider microscopic anemia clues treatment. The first treatment would be, since it is due to iron deficiency, I will do iron therapy, plus minus dilation. Rare but high yield syndrome. So it means this is very rare syndrome, but very high yield, commonly tested. Think Palmer-Benson when dysphagia is linked to iron deficiency and the patient has WEP. This is the wrap up of the whole lecture. First, divide dysphagia into oropharyngeal, esophageal. Oropharyngeal is when the patient cannot initiate the swallow. Esophageal when the patient can initiate but cannot push it down due to obstruction or motility disorder. Then decide whether the esophageal disorder is mechanical or motility. So now the patient cannot push it down. Is it due to obstruction or due to motility disorder? Now, solid only usually means obstruction. If the patient says solid only, I know that this is most likely to be obstruction. If the patient says solid and liquid, then I think about motility disorder more. Progressive dysphagia with weight loss and cancer is cancer until proven otherwise. We know. Bird's beak suggests achalasia. Corkscrew pattern suggests diffuse esophageal spasm. Lower esophageal sphincter tone plus connective tissue, less systemic sclerosis disease, suggests scleroderma esophagus. Oropharyngeal dysphagia is dangerous because of aspiration. Manometry is the key test for motor disorder. And thank you very much.